Hi guys, so it's Dr. BT and I want to talk to you about chapter 26, some tests which we do in pregnancy, and some of these tests do appear on the NCLEX and you will have them on my test. I'll be very specific about the test and the things that you need to know. So we're going to skip on down to assessment of risk factors. So you guys, we have to look at the patient as a whole and evaluate her risk factors to determine if she's a high-risk pregnancy. They've been they're in grouped in very broad categories, and we'll talk about those. Biophysical or any physical symptoms, diseases, conditions that can happen to the mom or happen to the baby, which can jeopardize both of them. Genetic disorders, genetic disorders, sickle cell anemia, any type of genetic problems, malnutrition or overnutrition, general health status, could be cardiac or blood pressure problems, or any medical or obstetrical related illnesses such as gestational diabetes or pregnancy-induced hypertension. Those are all things that can create a high-risk pregnancy. Psychosocial can create a high-risk pregnancy. We know that if you've had major depressive illness in the past, schizophrenia or bipolar disease, we know that these can be huge problems. Also, anorexia nervosa can definitely be a nutritional problem, which is psychologically derived, that can have a negative effect on mom and baby. It can include emotional distress and disturb interpersonal relationships. If mom does not have adequate social support, that could be a high-risk pregnancy. And of course, unsafe cultural practices, a good example of that would be, you know, if you're in a group that thinks you should go into the hot baths in certain mountains, like hot steam baths, of course we know that that could be a teratogen for the baby. Socio-demographic, you guys, just based on your demographic set, tells us if you're at risk. Rise from the mother and her family. Of course, if there's a lack of prenatal care, that puts her at high risk. We don't know her condition or the baby's. Low income puts them at risk for being able to have a good nutritional setup for diet. Also, low income could be barriers for to get medication, to get transportation to the clinic or facility they're seeing, and then of course there are barriers of care for the low income and um, for people who don't have access. Marital status, I don't know. And then ethnicity, just based on your ethnicity, that can make you a high risk if that ethnicity has more poor outcomes. Environmental, of course, it's a high-risk pregnancy if you've had an environmental hazard exposure, such as Zika. How about if you work in a dry cleaners? We know dry cleaning fluid is a teratogen. We know we don't want you under anesthetic gases if you provide anesthesia for patients, if you're a CRNA. We don't, we know those are big, huge risk, and we need you to be protected. Of course, we don't want you to be exposed to radiation as well. Those are high risk. So antepartum testing. So you guys, now we're going to talk about the test that we do on patients. And the most significant and the best test to determine fetal well-being, and I've talked about this a lot, is daily fetal movement kick counts. So you guys, we just know that if your baby is getting oxygen, your baby's kicking and moving. And so it's called kick counts. There are a lot of different protocols. So you guys, one big protocol says if there's any change in the routine of your fetal movement, we want you to call or come in. Or a kick count of fewer than 3 kicks in 1 hour warrants a further evaluation, warrants the patient coming to the hospital and the nurses to administer a non-stress test. That should be an alarm or that something is going on. A fetal alarm signal can also mean that there is extreme fetal movement and then the fetal movement stopped. So you guys, that is another sign to us that there could be problems. This is just your fetal movement chart, and we have moms, we give these to moms and they can document the fetal movement so that they can understand patterns of movement and they can see the last time they felt their baby move. Ultrasound is another test that we do, biophysical testing. And you guys, there are different ways that we do ultrasound. We do transvaginal very early in the pregnancy. You can see the probe goes into the vagina and then the uterus is really small. So it helps us to see the very small uterus. We do abdominal ultrasound later in the pregnancy because the uterus is so big. So what do we use ultrasound for? Well, the first thing we do is we verify gestational age. That's one of the biggest reasons we use ultrasound is if, well, the new ACOG guidelines say that we should verify gestational age in the first trimester so that we have good dates and we have better fetal outcomes. We can also monitor fetal heart rate activity with ultrasound. We do that when they're in the hospital. Fetal growth, we monitor fetal growth with ultrasound, and fetal anatomy. At 20 weeks, you have a big anatomy scan, and that kind of tells us if all the organs are have formed correctly and you're through the very significant period of organogenesis and fetal development. Ultrasound can also check for genetic disorders and physical abnormalities. We're looking very closely there. We look at the placenta and the position. Of course, we want it high at the fundus. We're looking to make sure that it is not implanted low, which would be, what would that be called, you guys? Yes, that would be called a placenta previa. We do not want a placenta previa. And then function, we're looking at the placenta to make sure it's not calcified. So you guys, for all these high-risk pregnancies that we have, that we know we can get calcification of the placenta, or we know that these pregnancies go past the due date, you guys, we make sure that this placenta is not calcified. If it's not calcified, we know we have good function. The level of calcification it can be determined by ultrasonography. And then we use ultrasonography as adjunct to other invasive tests such as amniocentesis. We use ultrasound to assess for fetal well-being. We can use it for Doppler blood flow analysis. So you guys, we can use ultrasound and look at the blood flowing through the cord so that we can see if there's any problems with the cord with the placenta. We can use the ultrasound to check for the amount of amniotic fluid. And then also, you guys, we use the ultrasound to conduct a biophysical profile. So if someone has a non-reactive, non-stress test, this is an area of concern. So we follow that up with a biophysical profile. So the biophysical profile is an ultrasound that has 4 parameters. It's the amount of amniotic fluid. And you guys, there should be enough amniotic fluid for the baby to breathe and to ingest and urinate. Fetal tone, we do not want a hypoxic, hypotonic, flaccid baby. We want a well-flexed, good toned baby. We monitor for fetal movement. We look inside and see if the baby's moving. And then we also look for fetal breathing in the biophysical profile. So those are the 4 parameters that we use to look at. The last section of a biophysical profile is a non-stress test. So they get 2 points for each. So they get 2 for amniotic fluid, 2 for fetal movement, 2 for fetal tone, 2 for fetal breathing, and 2 for non-stress test. We do biophysical profiles, you guys, on all these patients with these high-risk conditions such as gestational diabetes, gestational hypertension, drug use, inadequate weight gain, all of these things, you guys, we bring them in every week and we do a biophysical profile on them. Now, if someone has a non-reactive NST, we'll do the ultrasound so that we can have a full picture of a biophysical profile. And so you guys, this is Doppler blood flow testing, and you can see the blood going through. There is arterial and venous blood that you can see right here going through the cord, and then you can see the fetal heartbeat and the amplification. So we can always see if there's anything problematic with the cord. Ultrasound, the nursing role is, you know, we really just help. We have the ultrasound gel, and we have the towel, and we really just kind of help. So that's our big role, is helping with the ultrasound. We never tell the patient what we see on ultrasound. Of course, the ultrasonographer documents the information they find on ultrasound, and then the provider will review the ultrasound with the patient. We do 3 and 4 D ultrasounds. Um, uh, they really don't like, the ACOG doesn't like um, for people just to do them for fun, because there can be things on ultrasound that they find that could alarm the patient that was not ordered. Exposure of the fetus by the high frequency ultrasounds without clear medical indication is definitely not approved by ACOG, and they don't want unqualified people doing ultrasounds. Here's some ultrasounds. These are 3D and 4D, and you can really see what the baby looks like. And I understand why the patients want them. They're just very costly. They've made it into kind of a glamorous thing to get these pictures of your baby before it's born instead of a medical thing. And so it does increase it. They could incidentally find something that could alarm the patient, or um, they misinterpret what they see and they tell the patient that it's something that it's not. So we don't really like that. They can do MRIs during pregnancy. It's non-invasive. They can look at fetal structures, growth, placenta, amniotic fluid. They can look at maternal structures. Let's say we thought she had a hot appendix. We could look at that and see biochemical status of the organs, soft tissue abnormalities. So we can use MRI, although we try not to use it because it is there's some radiation that comes with an MRI. So with magnetic, it's just a small amount of radiation, but still in all, it's a little bit of radiation. Next would be biochemical assessments that involve examination and chemical determinants. So this would be when we're not looking. So the things we just talked about is when we look inside. Now we're going to use a specimen. So an amniocentesis is one of the first things that we have, and there are major potential complications with amniocentesis. Of course, anytime someone inserts a needle into your body, you're at risk for infection, you're at risk for bleeding. So those are the big two with amniocentesis: bleeding and infection. We could have RH incompatibility issues with amniocentesis. Of course, they'd have to, if they were RH negative, they would definitely have to have a RhoGAM after an amniocentesis. And then if we punctured the placenta, there's a risk for neonatal death. So why do we use amniocentesis? So we use it for genetic concerns, first of all. So you guys, if mom is over 35 and she's worried about a chromosomal abnormality, she is offered an amniocentesis to look at the chromosomes and make sure that or give her the information about the baby so that she can make adequate choices. We use the amniocentesis at term. We aspirate out fluid for fetal lung maturity. We aspirate the fluid, send it off, and we're making sure that the lungs are mature before we do a C-section or have a vaginal delivery on a gestational diabetic. And then, of course, we can do it for fetal hemolytic disease to find out the blood type of the baby. This is just kind of how it works. You can see that she's draped sterilely. She has a drape on. She's cleaned. An ultrasound prior to insertion of this needle showed us where the placenta was. So the placenta should be well out of the way of the needle position. And you want to make sure you don't puncture the needle, the cord, or the baby during aspiration of the amniotic fluid. So they will take amniotic fluid out. As you can see, they'll spin it down, and then we'll be able to do studies on the amniotic fluid. RH antibodies, chemical analysis, and of course, we can look for intrauterine infection, which can be a major thing. Now, you guys, we definitely know that there you'll see the clear fluid in there. That's the clear amniotic fluid, and we can get all the information we need out of the amniotic fluid. But we know that there are huge risk here. I almost said huge. Isn't that funny? Ha ha ha. Anyway, huge risk here for infection and bleeding and accidentally puncturing the cord or the baby. Chorionic villus sampling, you guys, that's another technique that we can use to determine genetic information. We use this very early in the pregnancy, between 10 and 13 weeks of gestation. And actually what happens is that we get a piece of the placenta. We go in, remove a small portion of the placenta, transcervically or transabdominally. Most of the times it's transcervically because the uterus is so small. Get a piece of the placenta, send it, and get genetic information. You guys, this is much higher risk for loss of pregnancy. This is a higher risk for an abortion than is an amniocentesis. So we really worry about this. The people who really want this are people who are serious high risk for genetic issues. And they want to know very early before they tell anyone, or they want to be able to make decisions about the pregnancy very early. And you can see this is done between 10 and 13 weeks. Here is how they do it again. Here's the ultrasound. You can go transcervically, get a little piece of the placenta, and then this is transabdominally. They take the ultrasound look here, and then they take the needle and come in this way transabdominally and get a piece of the placenta. The next test we'll talk about is PUBS, percutaneous umbilical cord sampling, also called chordocentesis. This goes directly to the cord. We're going to go through the mom's abdomen and we are going to aspirate blood out of the cord to see if the baby has problems. Particularly the biggest one that we think about is Rh incompatibility and fetal hemolytic anemia. So you guys, this is the one we use to see what is the hemoglobin of the baby in utero. So it's the most widely used method for fetal blood sampling and transfusion. We can get blood through there. Insertion of a needle directly through the fetal umbilical vessels under ultrasound. And you can see here it is. You can see they try to go really close to where the cord is inserted into the placenta. You can see it here. So the ultrasound, and then they can take a needle, come through here, aspirate fetal blood out of the cord, analyze it, and then they can also give a transfusion this way as well. Of course, anytime that a needle goes into the abdomen, you're at risk for bleeding, infection, and then of course fetal injury. Maternal serum assays. The first one we've already talked about is an MSAFP. This is also called a quad screen, and it's a tool for screening for neural tube defects in pregnancy. So remember, if it's decreased, we're at risk for Down syndrome. If it's increased, we're at risk for neurotube defects. And this is only a screening tool. This comes from the maternal blood. This is a maternal assay. So you guys, we're going to draw blood from mom. It detects about 80 to 85% of all neurotube defects and open abdominal wall defects in pregnancies, such as gastroschisis. And it's recommended screening for all women. You guys, we look for also autosomal trisomies, so we can see trisomy 21 or Down syndrome. Of course, again, this is a screening tool. If it is deemed a positive screening tool, we're going to send her for a diagnostic test, which would be an amniocentesis. Other things we can do is a Coombs test, and we've talked about this. So an indirect Coombs on mom during pregnancy to find out if she has antibodies against a Rh positive baby. Free cell DNA is the new trend, is to draw blood from the mom. Okay, draw blood from the mom, and it's non-invasive prenatal genetic testing. And so we can get a definitive diagnosis for RH, fetal RH status. How awesome is that? Fetal gender, and certain and other transmitted single gene disorders, which they are continually evolving, so I don't want to go into that. But we can get some gene disorders. It's performed as early as 10 weeks gestation, and they're usually good in about 10 days. And it's really funny because a lot of people who really want to know what the sex of the baby is. They're the ones who really want this test when we really are concerned about the medical implications of this test. This is just kind of wrapping it up. Fetal care has evolved with diagnostic and therapeutic options, and of course we always know that at the 20 we want to do these tests that if mom wants options for considering to maintain the pregnancy or terminate the pregnancy, these all need to be done prior to 20 weeks. And she also needs to have the information so that if she did not want to continue with the pregnancy, that this could be done well before 20 weeks. So meaning the genetic testing, the outcome, the time for decision, and then the time for treatment, all before 20 weeks. If you have any questions, please post them on the discussion board. Thank you.